with Dr. Monica Noguera. Dr. Monica is an assistant professor at State Hospital in Sao Paulo. She is pediatric orthopedic and limb reconstruction surgeon. And Dr. Monica was my colleague fellow in Baltimore, in Maryland, in 1998 and 1999. And we learned together how to do Ponseti method with Dr. John Herzenberg in Baltimore, as well as with Professor Ponseti in Iowa himself. He teaches us how to do method. Then Monica really did a great job in popularizing Ponseti method in South America and all over the world. Hello, Dr. Monica.
Hello, Yasser. Hello, my Egyptian friends. Hello, my friends from all kinds of places in the world. I'm very happy to be in Cairo today. It's very weird for the middle of the afternoon between patients to be in Cairo, but I'm delighted. Next time I will get to know the Nile River and the pyramids. But let's go. Well, I would like to talk about the relapses because that's my favorite subject, because that's a big challenge in Ponseti method. So I will dedicate into my tips and tricks what to do in relapses. So as we know, and we're gonna hear from the other speakers as well, the Ponseti method is a challenge because there's a biology that causes it. There's cells in the middle part and the posterior part of the leg and the ankle and the foot that cause the problem. So the problem is not teratogenic. The problem is not specifically from position. So there is something there in the soft tissue. So it's a soft tissue problem, then the bones adapted it. And because of that, there's a strong tendency to recur. So this is our stubborn feet that want to be again crooked. So that part everybody knows pretty well. But then the older kids, what happens when you take the brace out and children are allowed to move around and go on their lives, and they continue to grow, and they will have problems in the middle of the way because they have growth spurts that will make their feet and leg not to adapt very well to this growth, this longitudinal growth. So you have recurrences from these on the older kids, and this is less known and less talked about. So this is images from on the left from the Ponseti's book, as we know, and on the right from Ippolito's study that shows that the difference in the soft tissues are very important to explain this tendency to recur in the older children. So position is not a problem, as we know. There's a lot of liquid everywhere. So still some people believe that because of the position intrauterine, it would be a problem. But that will be a problem on the arthrogrypotic feet, okay? Because the biology is very different. From the idiopathic point of view, no, it's not a positional problem. Well, I've learned from my friends from everywhere in the world, but this I learned from NIA, the good things that we have to present and to talk to people for them to accept that the brace is not a burden. The brace is a nice thing because the brace saves us a lot of trouble, a lot of surgery, a lot of problems in these kids. And they're not really restricted, as we can see. They move around, and the movement is very good for them. And those are films brought by the father of this child to show that he couldn't be quiet. So we have to accept the braces as our fairy, because they are magic. They can be compared to skates, snowboards, and they have to have decorations because they are the big boss in this treatment to avoid relapses. And they don't cause any neuropsychomotor problem. And this is from nowadays. We don't know of any study saying that the brace will but we prevent children from develop properly. So this is very important. So the brace has to be, in my opinion, has to be national. Why do I say that? Because it has to be easy to access. And from different programs and of public services all around the world, that would be a problem if we depend on any special brace that comes from somewhere. So it will be very nice to have something that is produced in your country, that's not expensive, so it's accessible to families, light and comfortable. And things like having the straps on the medial side help. Things like have a posterior opening for controlling of the calcaneus will be a nice thing. And having the correct angles, not treated foot 70 and 40 or 45 and the other side, having a slight curvature. So all these details we know, but in a very simple, easy to use, comfortable brace, that will solve the problem. So many other problems, and this seems to be very obvious, but if we go one by one, we'll see that we can do a lot on this part of treatment, being orthopedic surgeons. Many of our colleagues have been delegating this to the parents only, and it's not what we believe today. That's the key in the treatment. So the feet are completely corrected. This is very important, because if the feet are not corrected, we cannot have the braces fitting properly, so it won't work. So make sure first that the feet are fully corrected, of course. The second is the brace properly set. So if the bar are too narrow, and if the angulations are not good, and if the foot are not corrected, you have a problem. So if we correct the foot and set the braces in the appropriate way, we won't have this problem. So which brace to choose? So the simple brace with the locked angles in the foot with the bar will solve the problem. So what about the AFO, KFO, and articulated brace? They are not the same. So the AFO, as the child rotates internally, it loses all the tension, so the Achilles does not stretch, so that won't work. Nowadays, we have a lot of people using AFOs for avoiding recurrences, especially on the older kids. And this doesn't help, because it won't allow the child to stretch the medial structures if they internally rotate. So the KAFOs, they keep the knee in flexion, so the Achilles again does not stretch. And I will want to bring one more time this study, this important study, which is in vitro study with sensors in the receptors of a model, a biomodel, and it showed that first, nothing bad happens in the knee on those braces because it's dynamic. So the tension goes on the soft tissues from the feet to the hips. So the whole medial part is stretched. So it's not concentrated on the knees, as some people are very stressfully telling that could be a problem of the knee. Also, and very important, if you have any flexibility in the bar or in between the shoes, it won't be as effective. And this is very important. As you show, as this study shows, the first, this part on the above on the right shows the maximum tension on the medial posterior structures. And if you go for the AFO, this tension decreases a lot. But if you go for the flexible brace or articulated brace, you have practically, this tension is completely gone. So this is a big problem. And that won't work, and that won't stretch. It won't prevent the recurrences. So this is very important. To do it as a routine, so apply the brace with the child awake, and do not change the hours. Sometimes it's 14 hours, sometimes it's 12 hours, for some families 10 hours. That doesn't help. So to be consistent is a very important thing. And to act like brushing teeth or putting on clothes, something that could be a ritual, like a sleeping ritual for the child. And sometimes at 4 years of age, when the braces are told not to be worn anymore, some children will have difficulties to sleep. So that's something related to the routine. So this is very important. So sometimes we think that the child will be very happy. That's not always the truth. Well, the parents put it well. As you see, it's a part of the clinical visit to have the parents set on the braces for the child. So you can see in a very relaxed atmosphere, and you see those children wearing and playing and not very nervous or irritated. So this is very important. So the parents must bring the brace to the consultation. It's also very important. And you have to tell these parents at the beginning why do you have to use the brace. So this is very important. If you don't explain to them, if you don't convince them, to convince them, you have to be convinced first that that's the way to go on the Ponseti method, and then you'll be able to convince the parents from the first visit, sometimes with the baby in the belly of the mom, but you have to explain to them to work as a team, not as different against each other parts, the doctor and the family members. And this is pretty new from the work on the programs we've been doing and seeing all around the world. So you see that having a reference clinic could be a good idea. So you have the reference clinic that has a lot of volume. You have a very experienced professional doing this, and all the parents are there supporting each other. So this is key also to avoid recurrences, as we've been seeing on these papers that came out. Okay, if we failed in all of that, what to do? So the most important message is, again, to do on serial casts, okay? There's not any mirabolant solution for this, because before 1 year of age and up to 4 years of age, the problem is very much related to not stretching it properly. And it's not a problem of the family only, as we talked about already. So the foot slips, the foot does not fit in, red skin, equinus, some varus. And then you have first loss of dorsiflexion, then varus and abductus, and at the end you have cavus again. So as this frame from Jacqueline Perry shows, that the solio is the most important villain in this recurrence, because it's the most shortened and it has the most inversion, the strongest inversion force. So as it shortens, as it's a little bit medial, the insertion, it pulls the calcaneus into varus, and all these events occur. So relapses are treated with serial casts. So there's less than 4 years of age, just the same protocols we have as the baby. So serial casts, tenotomy if necessary, and back to the normal brace protocol. And have we seen that even the 3 months, 23 hours a day is possible in many children, even grown up. And then at night up to 4 years of age. Okay, there's not written anywhere. We cannot find this in the book, but we've been seeing different ways of dealing of this situation. But on smaller kids, the protocol, the Ponseti protocol, is pretty much what we have to do. And then some people think that transfer of the anterior tendon could be a solution. And we don't like to say it before 4 years of age, because there's a lot of force in the biology to pull the foot back into the crooked position. And this has nothing to do with the pull of the anterior tip tendon. So the initial and original indications of inversion and adductus, indication of the transfer of the tendon, would be by Dr. Ponseti's green book. On the over 4 years of age with flexible, like we say, the dynamic varus, what he defines. So the feet are corrected, but when the child moves around, it goes in, every time he goes on dorsiflexion, he goes in, and that is an education. But that's quite rare. So the most common are the stubborn feet, the feet that recurs and recurs and recurs many times. And in one of these treatments, after 4 years of age, after the serial casting and tenotomy, you could do anterior tip transfer. As some people say, that could be the brace inside the feet. But we see that some feet are rigid and needs the brace as well for some time. So kids are not the same. So the anterior tip, as it's described in the book. So actually it's not a transfer, it's a transposition of the tendon, because just the insertion is moved laterally. And if it's done too early or not after correcting the foot, so that's a big problem. So if you transfer the anterior tip without correcting the foot, and you have a crooked foot with the anterior tip transferred, you still can salvage, but it's not so beautiful, because of course, as we stretch the foot, the anterior tip that was already transferred is lax, so you won't have the correct pull. So it's not a good idea to do it before a very good correction of the foot on the serial casting. So if the foot is crooked, it won't work. And those 3 kids, they're older, and they had the anterior tip done without correcting the foot. So they have crooked foot. So in this study, that we don't spend a lot of time talking about that, but we did serial castings on those children, and luckily, by far, on the 6 cases, we didn't have to change the position of the tendon, because they function quite well. But they are, of course, they have a weak dorsiflexion. So this girl had the anterior tip transferred without correcting the foot. Of course, it won't be sufficient to pull the foot in a correct position. So we do casts, and this is a Scotch cast that goes over just not to break the cast, but then you could salvage those feet. It's not beautiful, so the idea is not to make this work with the correct anterior tendon transfer before. So don't do the anterior tibial transfer before correcting the foot. So that's the message. So this is pre and post correction only with casts. So those are 3 casts. And you can see on the right foot, he had the correction before, but didn't work. And now it's quite weak, but he can go pretty well. And we didn't have to transfer or with retention again. So that was the message. So not to forget to transfer the anterior tip transfer tendon before correcting the foot. So you have to correct the foot first. So don't forget to go on the casts. I won't talk about our neglected, because my friends will talk about, Anna and Millen will talk about those feet. Just to say, it's not a sin anymore, and the literature is not sparse. There's a lot of literature on this. So I'm a big supporter on the older kids. Well, just to finish, a little touch on the myalo kids and the arthro. So myalo has a lot of clinical considerations, problems with the valvula, the head, and lack of sensitivity, propensity for ulcers, problems of tension on the skin, and a lot of problems. So very well molded cast is needed with total contact principle, and they have also muscle imbalance, and depending on the level, they can lead for many recurrences as well. In the arthro, they are rigid, they have comorbidities, tenotomies almost in 100% of cases, usually complex feet, as our friend from Bulgaria will talk about in detail, and the relapse rate are the highest. So if you compare the 2 groups of kids, on the myalo side, we had 43 children and divided on many different levels, and the age 2 years, 7 months, so not very young casuistic, this one. And on the arthro side, you have divided into amyoplasia and most of them, and distal some, and Freeman-Sheldon and other syndromes less common in less cases. And those were a little bit younger. The technique was exactly the same, elevation of the first ray and abduction, exactly the same way. And for bracing them, we had some fractures before we decided that we had to protect a little bit more of those legs, because the short brace would make a fulcrum, and those kids don't feel it very well, and when they roll around and they go around, so you have to be careful of them. So we do AFOs connected to a bar instead of a regular bar, usually on those kids. And then you have good results because you have a lot of stretching. And after the continuous use of brace, you pass on the night time only, and then you connect and disconnect the braces and the bar. You can also treat the ulcers with the Ponseti method because of the same principles they treat diabetic people. And so you have a contact, total contact treatment, and you do it, the correction goes and goes, and you are able to correct those kids. So the initial correction was very high, and you can see that in both groups, they were pretty important, and the maintained correction more in the myelo than the arthro, and tenotomy more in the arthro than in the myelo on those cases. And on myelo, you have skin problems a lot until we know how to deal with them and not to be afraid of having those problems. And on the arthro, you have the procurvatum of the tibia, complex feet, and fractures in the brace. Relapses were very high. In the arthro, you can look at 74%. In myelo, more of the half of the cases. And most of them are treated with new casts, and some of them went to posterior medial releases. So just some cases to illustrate. After 1 month, or what means 4 casts, we were using the AFOs at this moment, but he was an older kid, so fine. You can see if only 3 casts, we can change completely the alignment of the child and the relations of soft tissues, as you can see it. And in this 3 year, 8 months girl, you can also change the orientation and allow her to use the RGO correctly with 4 casts. And this is one of the girls that we treated the ulcers, so she couldn't get into surgery because of the ulcers, and so we did the Ponseti method, and she healed the ulcer and corrected the foot. Arthros, 3 cases to illustrate. So it's a distal arthro case in the right foot, and here he is at his follow-up, 11-year follow-up. He's 13 now, so 13. So in keep the correction. Here's one of the syndromic kids, older kid with arthro, difficult, and you can see the good correction using the braces to be standing. Here's one of the syndromic also, and big corrections you can do on older kids, as you see. Thank you. Sorry if I talk too much, but I'm very delighted, and I have many friends in this beautiful country. And Yasser and me, we had a fantastic time in Baltimore, and I'm sure we'll be keeping seeing each other many other times. Thank you.
Thank you so much, Monica, for your wonderful presentation. I really appreciate. And we open now for to answer some questions from our colleague.
Hello, Doctor. Hello, Dr. Yasser. Dr. Mabruk, how are you?
Do you hear me now, Monica?
Dr. Mabruk, I'm from Benghazi,
okay.
Libya.
Hi.
You can find in the chat section, Doctor. What question from Dr. Hassan? Hello, what about the correction of the big toe? Question to Dr. Monica from Dr. Hassan from UK. How do you decide whether to to transfer tibialis anterior partially or completely?
Okay, let me go one by one, if you will, because there's a lot of things going on here. So if you talk about the toe adducted, that means for me incomplete correction. So it's very important for you to stretch the whole part of the medial part of the foot on your chest, and especially if you're at the end, don't be shy to abduct. Okay, Anna will talk about that for sure. You don't have to be shy to abduct on the older kids. You can abduct and you will stretch this part. Still, some children keep let's say dynamic toe walker in adductors, but then those kids, as I've seen, I'm not, there's not a study on that, but just a report, they improve, okay? But not a deformity that's fixed. So you need a lot of abduction to have this toe completely aligned. Some people think that if you have a little bit here is fine. It's not fine, because before we had this on the surgical feet, we accept it, but now we can get a good result doing this, being very picky with this alignment. Well, dividing the anterior tib is not a good idea, as we use for the neurologic patients, especially on CP patients, because the problem is that the anterior tib is a deforming force. So if you don't take it from there completely, you won't get rid of the problem that he will keep coming in. So transfer and complete the tendon. So because you're doing a complete transfer, you have to function well. So you have to tension it well. You have to really thrust on your cast at the end of your transfer. It has to be a very nice cast. So if it's not a nice cast, the bottom, the pull out, if you're using this technique, can come in the foot because the tension is very, very high, and you lose it, your correction, you lose the force. So I don't think there's a place on the half or EMI anterior tib on this idiopathic club feet.
Okay.
Thank
you.
Can I add anything, please?
Second question is from Dr. Ali Zaki. He's asking about if in some atypical cases you have DDH and you operate the patient with DDH, how to deal with the Dennis Brown splint after operation and casting for DDH problem.
Okay, Anna, what would you like to say? Anna?
Yeah, I see you. Yeah.
Yes, about the questions. The first one about the EMI, the second one about the EMI transfer, for me is no place for EMI transfer in Ponseti method. For me, there is no place, nothing. No patients are indicated for EMI transfer.
All it's the deforming force. Yes, I agree. I agree very much.
And in the question about the first two, there are some patients that you can do a lot of cast, and you have an hypertone of adductor of the hallux, and you can do a percutaneous myotenotomy that is very effective, helps a lot to the satisfaction of parents, and is a very easy procedure that you can add when you are doing the transfer. Just this.
Yes, around the DDH question. Well, as we know,
I'm treating the feet, and usually I'm treating the DDH at the same time. If there is a dysplasia, to put a big bar, it helps because you are doing abduction. And if you are treating a dislocated hip, you will need to put an harness. And
yes, I think the hip is very urgent
to operate. But if you need to operate, you have to know that you will lose the correction of the feet probably you can use the correction. So you have to elect what is your procedure. But first, I tried to correct with the Paulic harness. If it maintains a dysprasia, I'm putting a big bar, and it is, in most cases, I have corrected just doing that without any other harness on any other orthopedic brace. And if you need to operate, you have to explain to the parents that if you operate the hip, you cannot put the brace of feet, and you can lose the correction, you can have a relapse, and first one thing and after that the other. That is my process.
Yeah, sir. I think if there's a different situation if it's a baby, a newborn, or a grown-up. Okay, if it's a baby, the hip is more urgent than the feet. We know.
I don't agree with you about it. No,
and
never have any emergency, I think.
Yes, and no, hip are emergency because you can treat. Yes, that's what I'm saying. Yeah. Yes, that's what I'm saying. So you can use the Pavlik with the cats at the same time.
It works.
No problem.
It works.
And it works very well. And you keep, and sometimes, usually, the numbers of the ultrasound will improve up to the point that when you put the brace, the abduction brace, you're fine. Yeah. But of course, if you have a grown-up, like a 1-year-old, so do the hip first, and then you do
you have to continue with feet.
Because if you treat the feet first, you lose it, because you need a plate. You need to maintain it. But of course, you have to hush. Yes, you have to hush to save the hip. So as sooner, better. Okay, the feet. If it's some months after, and if it's 1 year after, it will save no problem.
I agree with you about it. Yeah.
Yes, sir.
Okay, Monica. Second question is from Dr. Vikram Khan from India. He's asking about till which age you keep the brace, because he says that he keeps the bracing until age of 5 years. So he's asking you about the best age to keep the frame.
Thank you, Yasser. Well, the thing is that the protocol, the international protocol, we came around when about in the 2000 year was up to 3 years of age. Okay, because even in the Green Book, Dr. Ponseti says 2.5, 3. But we know that's not very nice, because the child has a very big tendency to recur. So at 3 years of age, the tendency to recur is 20%. So because of that, internationally consents would move into 4 years of age, where the recurrence rate would be 10%, more or less. So 10% is nicer than 20%, which is a double, okay? And the child is well adapted and no problem. Okay, fine. Some people will keep it up to 5, but truly the ones that will benefit from 5 would be the ones that are more rigid, the ones that were complex when they were babies. So the ones that have problems in rigidity of the foot. Actually, the brace is not completely unproblematic. So just to keep it to, eternally, it's not a good idea, because you have concerns of the knee when they sleep. If it's too much increase on the tension when they sleep, and the medial side, you can have patella problems. And the brace is, let's say, a weakening device. Is that stretched very, very well. So the feet are quite weak. So that's why you have to check your child, what's going on. Some people are very, very relaxed, and you don't let the brace go because the protocol is rigid. But it's very nice to have the protocol as your guide, because this is very important. Some children that were very flexible, they changed, and then in the first visit without the brace in 3 months, even if they were 3.5 years, more or less, when they have, you know, you can leave the brace and the wardrobe, as I say. So what they do is they come back in 3 months, and suddenly they lost all the dorsiflexion. So if they lost all the dorsiflexion, the brace will come again. You don't have to wait for the recurrence to try to do something. So you keep seeing the child. This is very important. Some people think that because of the 4 years of age or 5 years of age, you just stop treating the child, and that's not very good, because you lose a lot of those kids for recurrence.
Thank you. Last question, because I know that it is now afternoon in Brazil, and you have to go for operation, as you mentioned to me. Last question is from Dr. Mohammed. I'm sorry, I apologize for everyone. I cannot take all questions, otherwise we are going to stay until tomorrow. Last question from Dr. Mohammed Elwash. He's asking about in case of arthrogryposis and the patient has DDH and knee problem. So what are the priority for management?
Nice, thank you. So this is challenge, okay? Challenge. So when they're babies, so if the hip is completely out, go like a teratologic dislocation, so you cannot use pelvic harness, so go for the foot, okay? So the feet can be corrected and maintained in the brace and no problem, okay? Different from a very flexible, most idiopathic, like a DDH, normal DDH. So in teratologic, that the hip is completely out, because you won't operate a newborn anyway. So until you wait for the hip to improve, you correct the feet, and you correct the knee as well, depending on, of course, for extension problems, okay? So you flex the knee little by little, and if it's very, very bad, you can use the Y techniques on the quadriceps and all these kinds of things, depending on the severity of the patient. So if they are very, very small, people wait for the foot. Maybe it's not a good idea, because if you do a very good try on the foot and the knee, you gain a lot of time. And even if you relapsed after, you can recuperate. You can go and after the problem. But the hips, if you have to operate them, because they're not treatable by Pavlik mostly, you have to wait for them to grow a little bit. So you treat the foot and the knee. Okay, so you have to customize case by case, but usually I'll do that.
Okay. I do some one exemption only. Last question for question from Dr. Yaqub al-Mufarraji from Oman. Dr. Yaqub is asking about for arthrogryposis. Do you only do tendo-Achilles stenotomy or posterior release also?
Hey, Doctor, Oman is a great place. I loved Oman and the Sika. That was very nice to be there. I'll tell you that we try as a Ponseti doctor to go only on tenotomy, because every time you go posterior release, you go and scary tissue will form and you have relapsed, very wild relapses will come. So if you can, gain everything that you can on the cast, and not depending on tenotomy for 30 degrees, because that wouldn't give you 30 degrees. So you have to correct all you can on the subtalar joint, and then you have the ankle just a little bit, and you gain a little bit on the complete tenotomy without going there on the posterior. You always can do the posterior release, but the problem is that you have more relapsed because you have more scar tissues and you have more trouble then. Those kids will relapse wild when they have a big scar on the posterior part. Okay, well, I'll talk to Yasser and try to see all the questions on the movie,
Yeah,
then, and I'll try to address each one to be nice, because it's really a good time, and I'm very happy, and I'm happy as well that you're recording, because I won't be able to watch my friends, but I really want to see their presentations, the valuable presentations. Big kiss for you, Anna, and Milin, and my friend from Bulgaria, and I wish all a very good seminar, fantastic idea, and see you soon.
Thank you so much, Dr. Monica, for your great presentation and answering our question. We are very glad and happy that you are with us today. And I think everyone enjoy your presentation and your. Thank you so much. Thank you.
Thank you, Yasser.
Now we are going to the second lecture from Dr. Milind Chowdhury from India. Dr. Milind is honorary professor of llizarov Institute since 2016, and he is the editor of Journal of Limb Lengthening and Reconstruction since 2015. Dr. Milind is director of Center of llizarov Technique since 1989, and he trained 100 orthopedic surgeons in clinical fellowship with him. Dr. Milind conducted 8th Assami International Conference in India now, and I'm really very happy that Professor Milind with us today, and I really always enjoy his presentation during the International Congress. And welcome, Dr. Milind, is in our webinar with Egyptian Pediatric Orthopedic Society meeting today.
Thank you, Yasser. Thank you very much for your very kind invitation. It's I'm glad to be amongst you all in Cairo. It's close to midnight in India, but I'm sure it's a lovely evening in Cairo, one of my favorite cities in the world. I've been there more than 3 times. Can you hear me clearly?
Ali.
You can hear me? Yeah. Okay, so thank you all. Yes. For this very kind invitation. So I will be taking this topic further onto kinesiological correction in neglected clubfoot in older children and adolescents. So when we have stiff and scarred feet in older children, and either they are neglected or they're complicated or complex club feet that have been operated a couple of times, there are scars on the posterior aspect of the calf and the ankle, or the feet seem to be very rigid, then it's not really a choice to be able to perform a Ponseti casting on the older children. And this is where the role of external fixation comes in. So in this group of patients, we have the indications for llizarov for either idiopathic club feet or myelomeningocele or an arthrogryposis, and even sometimes very in post-traumatic club feet, which can be rather very rigid. So the thing about neglected and relapsed club feet is that there's stiffness, and the tricks up the sleeve of neglected club feet are that there may be hidden talar dome flattening. So, and there may be incongruity of the subtalar and peritalar joint surfaces. So we'll come to the indications when we see older children with club feet or adolescents. We have to first look at the talar dome. If the talar dome is spherical, and you can take a judgment call that there's some movement remaining in the ankle joint and the talar dome is spherical, then we may be able to get away with soft tissue distraction. If, however, the talar dome is flattened, then we will not be able to distract the ankle apart and bring it into the plantigrade position. And we need to perform an osteotomy correction, leave the talus where it is, and perform the osteotomy either above the talus at the supramalleolar level or as a U osteotomy or a V osteotomy in the hind foot, and bring the foot around the talus and make it plantigrade. So this entire talk is going to be with the presumption that the talar dome is spherical and that we are going to employ soft tissue distraction to achieve correction of the club foot. Now the question that arises is, does the hardware really matter? Does the hardware have to be a very sophisticated one like the Taylor spatial frame or the TSF fixator? Or can it be a simplistic fixator, which is for example, the JES fixator, which is very popular in India and in several other countries. It's the Joshi's external skeletal stabilization system. It's a very simple fixator that goes on. It's very easy to apply, and it can give some very wonderful results. Or should it be the simplest, like the plaster cast? Or should it be the Siberian one, like the llizarov? Or the question is it the hardware that's important, or is it the software that's important? So we come to realize that it's actually in the software, and what really matters is the sequence in which we correct the clubfoot. So we've learned from the great man, Professor Ignacio Ponseti. I had the great privilege of being with him in the year 2002. And we all have learned from him the art of the sequence of how to get the clubfoot correction right. So even when we see much older children, we can use the very same principles. But before we go on to that, just a few very basic things about the definitions of the movements, if I may. Hopefully this animation will run so that we are not confused about the definition. That an equinus, looks like this one is not running. So let me just move on. Check for a moment. Unfortunately, it's not. So I'll go on to the definition of supination. It's a combination of adduction, equinus, and inversion. And pronation, contrarily, is a combination of abduction, calcaneus, and eversion. So in the Ponseti sequence, we know that firstly, we need to supinate the forefoot, which allows us to correct the cavus. That's the drop of the first metatarsal is corrected by supinating the forefoot. This may be counterintuitive because the hindfoot is actually more supinated as compared to the forefoot. So just to reiterate, we first supinate the forefoot, then we abduct the forefoot with counter pressure on the head of the talus. And then in so doing, allow the calcaneus to abduct from underneath the talus, and then finally correct the equinus. So the very same sequence we try to employ using the llizarov fixator. So we formulated this construct with the llizarov, which allows us to faithfully replicate the method in which we first have a construct for supination, then very special manner in order to get the right amount of correction. So let's look at this young child who's 8 years of age, who's had a soft tissue release in childhood. He did very well. It's a posterior soft tissue release. And he's got a recurrence of the deformity. As you can see, he cannot squat. So we use the llizarov fixator. The basic frame has got 2 rings on the tibia, 1 half ring in the forefoot, 1 half ring in the hindfoot. And there is a dropped wire from the tibial rings with an olive from the lateral side, which is giving counter pressure on the neck of the talus. And we perform this correction in the very same sequence that Professor Ponseti taught us. And in so doing, we are able to, supinate the forefoot, abduct the forefoot, and then in the hindfoot, we can achieve the correction by using a push construct from behind, in which the push construct has to be tangential to the talar dome, because the talus has to rotate and glide into the ankle joint. It has to glide posteriorly into the ankle. So when we perform the final equinus, the motors that correct the equinus must be tangential to the talar dome, almost perpendicular to it at every point in time. I'm really hoping this animation is going to run. If it doesn't run, I'll take a minute of your time and run the animation as a sequence, as a separate from the presentation, because it'll really add to the understanding that we have. Okay, so this is very surprising because the animations always run. Can you see this animation now? Yeah, sir? Can you? You're muted.
So the screen is freeze.
Okay,
so
yes, I hear you well.
Okay, so let me.
Oh, go on.
Okay, can you see the animation?
Yes, I see. Now the animation, no.
Okay.
No animation. Just,
give me a moment.
just a photo now.
Give me a moment. I will stop the sharing and I will share again with the right, thing that I'm trying to show. And this will take just a moment. Can you see this now?
Actually, the animation is the most important part of your lecture. I know.
I'm having trouble today, but normally works. I suppose you still can't see it, but all right. I'll just take a minute because these are some of the crucial things we learned when we. All right, so I'll bear with me for a moment while I, just do this again in a brief while, because it really adds to the understanding and. Very interesting. Usually it doesn't happen like this. All right, I'm trying to show the animation from just the file, but the screen share does not show it. So if anyone can, give a suggestion. I have the animation running separately, not in the PowerPoint. I can't seem to get into the PowerPoint. And I need to be able to show this in the PowerPoint presentation. Okay, yeah. This will work. Can you see this now? Yeah, sir?
Okay, yeah, I see now. Yeah, fine.
You see the animation, do you? Can you see it?
Now, no, now I see the table.
Okay, now you see the
Go
table.
for the video.
Yeah. So
I can see the playlist. Now,
stops.
just go for the video, please. It was working.
I switched to Mac because it never gives a trouble. But okay, just give me a second. I'm going to run this again because it stops running. So,
Okay.
all right.
So I can, if you need, I can do my short presentation for 5-10 minutes, and then you check your problem and you solve it. And okay, now it's working now.
Yeah, so that's the moment arm.
Okay, fine.
So the moment arm is the line joining the center of rotation to the point of application of force.
Okay.
When you apply the force exactly perpendicular, then the correction is perfect and the ankle joint does not get damaged. And if at all, can you see it now? Yes? This is the center of rotation of the ankle. The moment arm is the imaginary line joining the center of rotation to the point of application of the force. The force F that you apply with the motor rods or the distraction rods resolves into two vectors, F1 and F2. Now, these are perpendicular to each other. If this vector F is at right angles, then F1, the harmful vector, is 0 and all the force is transmitted along the center of rotation of the ankle. And you get a perfect correction around the ankle joint. If, however, we do it wrong, do it in such a way that it doesn't, if the force vector that we are applying is not perpendicular to the so this is the moment arm from the center of rotation. And if we apply a vector which is at an angle theta, let's say 30 degrees, it resolves into two vectors, F2 and F1. Here the F1 vector gets a different direction, and your ankle joint can be translated anteriorly, or it can get crushed into the ankle joint, or you can get an over distraction. I'll run this just once again to emphasize the point. The center of rotation of the ankle is at the lateral process of the talus, the imaginary line, the moment arm to the tuberosity. And if you're not perpendicular to it, and if you're at an angle theta to the perpendicular, it resolves into several vectors. Some of them may be harmful, and you can get an anterior subluxation, or you can get a crushing. So this is what can happen if you are going to have, if you're going to have a force vector that's not carefully calibrated, and one has to take care. So, back to the presentation. So we had the, so this is what we have in this young child. We have got a very good correction of his ankle. It's not over distracted, it's not crushed. And you can see he's got a full correction of his, he gets ankle dorsiflexion also, and he's doing well. Now, what if you have somebody who's much older like this with a very dramatic clubfoot? She's 20 years of age, but the talus is indeed round in the ankle joint. So what we can do is, first, the question that was asked by somebody about soft tissue release. Now, sometimes in much older patients, we can perform a posterolateral soft tissue release, not a posteromedial, because it's the posterolateral structures that are hindering the talus from coming inside the ankle mortise. So we release the calcaneofibular ligament, we release the posterior talofibular ligament, the posterior tibiofibulosyndesmotic ligament, and this allows the fibula to spring open and allows the talus to come inside the ankle when you distract it. So this is how we do it. This is the llizarov frame. This is the forefoot ring. The forefoot abduction is complete. And you can see in the close-up here, the most important thing, while the forefoot is being abducted, the hindfoot remains free. So you can see this, the hindfoot and forefoot are loosely connected with this lateral connection. This is the talus wire. This is the tibial frame, but the hindfoot ring is allowed to rotate free of, and it remains away from the bed with this, extension of the frame. So the calcaneus can also rotate. And then finally, you put on the, you put on the specific animation, the motors for the hindfoot correction. So again, I'll just take a minute, to show you the right animation. And this will take just about half a minute now. I think we are, so I have to, I'm going to share this in a moment. And this is, where are we? Stop share. And again, share the screen. This is the one. Right. So I hope you can see the animation. This is, I'll run it again because it's showing now the final part of the correction, the hindfoot inversion, and finally the hindfoot equinus. So there is a little bit of a, it's not perfect, the drawing, but you have to change the hindfoot motors so that they remain perpendicular to the moment arm at all times. And when you do that, you are able to, I'll run this once more for you. So this is how we do it. And so this is the forefoot supination being corrected. It's a force couple, like you're turning the steering wheel. You pull up the inner border and you supinate the forefoot to match the supination of the hindfoot. The cavus is corrected. Then you abduct the forefoot with these motors. The talus wire is preventing the talus from moving. The calcaneus rotates from underneath. It abducts underneath the talus. And when it reaches an apitalocalcaneal angle of 20 degrees, then you are free to do any residual correction of inversion. And then finally, the equinus. So, so the equinus motors remain perpendicular and they need to be changed a couple of times so that we are, we are able to achieve perfect correction of the ankle joint and not run into difficulties of any sort. So this is essentially the way in which we have done it. And you can can see that the ankle is very nicely
تعال حبيبي تعال.
constituted. And
دوبك تعال.
can you hear me? Am I audible? Yes, sir.
Yes.
Okay. Yes. Okay. So we have seen some problems in sometimes we've seen one child with a lower tibial physeal separation. Now we add wires in the lower physis. We can sometimes see calcaneal thickening or talocalcaneal separation. For that, you have to turn the talus wire down and fix it to the calcaneum. And of course, you have to do the bracing. And if you're going to get recurrence, then you have to perform the anterior tibial transfer. But what we have not seen with this method is a subluxation of the ankle joint, or a crushing of the cartilage, or over distraction, or a rocker bottom foot. I'll finally end with two cases. This is a mother of 4 children, 33 years of age, with a residual club foot like this. There is some movement in the talus and it's not flattened. So we can perform the correction using soft tissue distraction. She has got enough place for us to place half ring for the talus wire, and we can perform the maneuvers. You can notice the direction of the angle of the hindfoot motor. It's not vertical like this. It angles perpendicular to the hindfoot frame, and it allows us to get a very good correction. You can see she can even squat. There's dorsiflexion of the ankle as a result of this. And I'd finally like to leave you with this new concept that we are trying out in very complex club feet. There is a role of shortening. This is a young doctor in training. She has myelomeningocele with very rigid club feet, and she is bilateral at the age of 20. So instead of struggling with the soft tissue distraction, performing a soft tissue release, we chose to perform, as you can see within the frame, this is a Z-shaped incision. We resected the bone on both the sides, achieved shortening of the limb that allowed relatively the soft tissues to easily lengthen. And in a much shorter time, she was able to correct. You can see the frames. We allow them to walk also with bilateral, and she achieved a very good correction in a much shorter time than one would expect, if we just did a soft tissue distraction. So here again, I thank you very much for this very kind invitation. And sorry about the glitch. It's never happened before. There's always a first time. So thank you again.
Okay. Thank you so much, Dr. Milend, for your nice presentation. And really, I appreciate, and I think everyone learned a lot from your presentation about using Ponseti principle and llizarov device. Personally, I used to use llizarov for long time for correction of complex cases of clubfoot. However, since almost 8 to 9 years, I decreased the rate of using llizarov, and I do just Ponseti with casting, and it worked in many cases. It takes longer time, I'm sure, and I keep only llizarov for complex cases that they are not able to come every week to do casting or manipulation, and we need to correct them very fast for some economic reason for the family or so on.
Yes.
Now, you agree with me about this?
Yes, sir. I agree with you. Even though I started this method, I use it very less. And in a lot of even the older children and adolescents, I use casting. The only difference is that it's a below knee cast, and the cast is kept on for much longer because it allows softening of the soft tissues. And with a little posterolateral soft tissue release and a lot of casting, one can correct many of the club even in older children. Yes, I agree.
Yeah, thank you. Now we go for to answer some questions. Question from Dr. Hassan Khadim. He's asking to Dr. Milend, before you apply llizarov procedure, do you select your patient according to the family status or the area they live in, or you keep them in the hospital?
No, that's a very interesting question. Yes, it's difficult for people to stay in the hospital for a very long time. And, if it's possible for you to arrange for them to stay in hospital, it's a good idea, but the fixator can be on the leg for 3 to 4 months or even more. And yes, if the patients are not able to come for a proper follow-up, then it may not be the best idea. Then you may want to try some other method, like a one-stage correction, like a triple arthrodesis, or a wedge resection and correction. And if they're really finding it difficult to follow up, then it's not a great idea to put on the llizarov. So either you keep them in the hospital for all the duration, or you just do some other method, like a soft tissue release with a triple arthrodesis, that may be a better idea.
Another question from Dr. Ahmed Ikram. Do you put all the distraction rods in the first operation? He means that during the operation, or you put the distraction rod later on in your clinic during the follow-up visit for the patient?
Yeah, this is a very interesting question. Like I showed you in the animation, first we are correcting the forefoot supination. So it's a different construct. And then after the forefoot supination is completed, then we change the connections in the clinic without anesthesia. We drop a mortar rod, tibial assembly, going onto the forefoot ring, which abducts the forefoot. That's a separate assembly. It can take half 1 hour to assemble. And the third thing is, finally, we correct the equinus. The hindfoot equinus is corrected also by a separate connection. So the connections are changed. The montage is changed in the clinic. So we have at least 3 different changes, minimum 3 changes. And even for the hindfoot correction, like I showed you, you need to change the correction once. So if the patients are really keen on getting a good correction, the llizarov may be a little complicated. This may seem like a complicated method, but it tries to faithfully follow the principles of Ponseti, and it gives very good results.
Okay. I know that everyone practicing llizarov should know very well the principle, especially for the foot, as you mentioned, because personally I saw some disastrous cases. I think you saw similar some cases. If the surgeon apply llizarov and doesn't know where to apply the distraction rod, where to do compression, where to do distraction, then disasters will happen. Another question from Dr. Miroslav Zivkov. No, from Dr. Ahmed Ikram also. What about the tendon transfer to prevent recurrence?
Yes, yes. After the fixator removal, some period of casting, some period of bracing and tendon transfer of the tibialis anterior, if required, definitely it has to be done. And in some cases, I have also performed a triple arthrodesis in the really older people, patients. You also need to do a triple arthrodesis. The advantage of using the distraction first is that you don't have to resect too much bone, and minimal resection of the articular surfaces, and the triple can be done at the end of it. And also there was a question about foot stiffness. I agree with you. Foot stiffness is possible, number one, especially if the ankle joint is going to get crushed, if the ankle joint is going to get subluxed, and if we are, not really following the kinesiological principles, if we're going to take too long. So it's definitely, things can go wrong and you can get stiffness. It's a little advanced technique when you have mastered some of the basics of the llizarov. And I agree with you that a short, stiff foot is better than a long, stiff foot. So one has to be judicious in deciding. Also, it begins with deciding whether the talar dome is flattened or it is spherical, and it really is amenable to soft tissue distraction.
Thank you so much, Dr. Milan. We really appreciate your presentation, and we are very glad that you are with us today with the Egyptian Pediatric Orthopedic Society. And I think now is almost midnight at India, and we will leave you to sleep in peace now. Thank you so much, Dr. Milan.
Thank you, Egyptian Pediatric Orthopedic Society. Thank you. Good night.
Thank you so much. Thank you. Thank you.
Now it would be an honor to Dr. Yasser Batrawi will present a short talk on his personal tricks on Ponseti. Dr. Yasser.
Thank you. Okay, I'm ready. I'm going to present just a trick for during applying the Ponseti method. During applying Ponseti method, during manipulation and the casting, I noticed that when you apply cast, sometimes you find it happens that the tools become crowding like this. So what I did, my personal trick is to do spreading of the tools during the manipulation and the casting. I will show now you how to do to avoid the problem of crowding of the tools. This is a video. Ali. Ali. عايز اقفل الصوت بتاع الفيديو. اقفل الصوت بتاعه. Okay, during this is the stockinette, and I apply this in this way between the tools to spread the tools during manipulation and later on during the casting, as we are going to see. Okay, and this is the second video. And this is when during applying the casting. This is a soft cast of 3M that I used to use in my patient. We have to apply medial strut like this, and then to roll on over.
Yes, sir, excuse me, we can't see video.
There should be two doctors doing the technique together.
Dr. Yasser, the video is not working.
We cannot see, Professor. We
Sorry,
don't see. We don't see any.
What is the problem?
The video is not working.
Ah, the video. I can see the video. One moment.
No, we can't see. We can't see the video.
Okay, one moment. I see the video in my computer. One moment. Ali. السكرين بتاعتهم فين؟ السكرين نفسها. هات لي السكرين بقى، شير فيديو اهو. عايز اشيل الفيديو ده من الأول. Do you see now the video? Can you see the video now?
Yes, okay. Yes, doctor, yes.
Okay. Now, this is, I use a soft cast of 3M. This is the medial strut, and then rolling on over. Did you see the first video?
No.
No, doctor, yes, no.
Okay, so I'm sorry. We stop this one. I can share video. Stop. وقف ده كده. وقف ده، لازم نعمل شير. عايز اوقف الفيديو ده. انت كده قفلت ال اوكي. Okay, again. Do you see this video now?
Hello?
Please play the video, Dr. Yasser. The video is, we can see the icon, but please play the video.
You don't see any video now?
No. We see the screen of your computer.
مش عارف ايه المشكلة.
So when you play the video, try to share your screen.
I can see the video in my computer.
Yeah, but share your screen. Share your screen.
Share a screen, yes, I did. Do you see now?
Yeah, now we can see it. Yeah.
Okay. Okay. This is the stockinette, and then I have to apply the cotton piece in this way around the tooth to spread the tooth in this way before casting. And this is spreading prevent crowding of the tooth during casting. And we will show the casting now. Stop this one. Okay. You can see now how the tools are spreaded. And then share screen. Okay. You can see now the video?
No, not yet.
No? Do you see now anything?
So just we see the icon, but it's freeze.
It's working now?
Dr. Yasser, I think you have to close your share screen and then open it up again when the video works.
مش شغال معاهم مش شايفين. لازم نخش الأول على الشاشة على الزوم. هذه الشاشة.
So
Do
now
you see anything now?
Yes, it's working now.
It's working now?
Yes.
Okay. This is a soft cast of 3M that I like to use for cases of Ponseti. This is the medial strut. And then rolling around. مش شايف بقى بتاع نفسها اللي هي خليك على الجنب الشاشة بتاعت زوم نفسها. And abduction and external rotation is molding. With a soft cast, you have to roll it and then you apply the water after.
So there is a question. So this is a soft cast, not a hard cast, right?
Yes, soft cast is different from the Scotch cast we used to use in the, for casting in our case. And now I show you. This is. Do you see now the photo? Do you see the photo now?
Still we see your screen. Yeah, we got the idea that we see the small icon for the pictures, but it's still small.
Okay, do you see the photo now?
Yes.
Okay, you can see how the tools are spreaded without crowding. Okay, This is the only trick I like to share with you today.
Okay, thanks. Thank you.
Okay, thank you so much. Any question?
There are questions about is it easy to do Ponseti using the fiberglass? Dr. Ahmed Hazem.
Easy to do Ponseti with fiberglass. Yeah, it is possible. It is possible, but it's not. The problem that the fiberglass cast or Scotch cast is not well molded. The best, really, the best is the normal or the regular gyps اللي هو الجبس اللي احنا بنستعمله. This is the best. It's much better than any other kind of cast. However, I like to use a soft cast of 3M because it is lighter in weight and more human than the regular gypsy. I see that also Dr. Leo Taleb is asking about fiberglass and maybe working behind them. Okay. I think no more questions. We go now for a presentation of EVA company, and we have 5 to 10 minutes break and watch the company presentation. Dr. Boulis and Dr. Sami.
Thank you, Dr. Thank you, Dr. Yasser. It's a great honor to be with you, the Egyptian Pediatric Orthopedic Society. It's a great honor, and it's actually it's the second time to be with you, Dr. Yasser. And in a few minutes, I will highlight 2 of our products. The first product, Ensilacox Etoricoxib, 60 milligram and 90 milligram, 2 concentration available in the Egyptian market. The Etoricoxib take the European Medicine Agency EMA approval 2008. This agency concluded that the benefit of Etoricoxib medication overweighs the risk when used treatment of rheumatoid arthritis and ankylosing spondylitis. Ensilacox provide to you highest quality. This is a bioequivalent study shows that Ensilacox 90 milligram is equivalent to the brand Etoricoxib available. Ensilacox provide to you 3 main benefits to your patient. First of all, I will illustrate it later. First, I would like to highlight that Ensilacox is available in 2 concentrations. The first concentration, Ensilacox 60 milligram, its price in Egypt per strip 49.25, while the Ensilacox 90 milligram available in 30 tablets. Each 10 tablets or each strip price is 52.25. This is a highly economic product and compared to other Etoricoxib available in the Egyptian market. I would like to highlight the 3 main benefits of Ensilacox. I think all of you would like to hear. The first benefit is about the potent effect Ensilacox provide to your patients. This study show that Ensilacox 60 milligram is equivalent to diclofenac 150 milligram daily. This ensures to your patient how is Ensilacox is very potent effect that 60 milligram is equivalent to 150 milligram diclofenac. The other study concluded that or highlighted the highly safety of Ensilacox versus naproxen. These studies show that or compared between Etoricoxib or Ensilacox 60 milligram versus naproxen 1000 milligram, and this shows that the etorecoxib efficacy and safety on GIT stated for 138 weeks. This is a very long time, almost 2 years and a half, for taking non-steroidal without any complications concerning the GIT safety. Ancilla-cox, one of the benefits is ancilla-cox is to be taken once daily. Most of our patients complained from they did not take the product, and this benefit ensured to your patients high compliance for your patient to be taken once daily and cover the whole day. Ancilla-cox recommended doses 60 milligram for osteoarthritis. This is the maximum recommended dose. The maximum recommended dose for osteoarthritis 60 milligram once daily. The maximum recommended dose for rheumatoid arthritis 90 milligram once daily. The maximum recommended dose for ancilla-cox in ankylosing spondylitis 90 milligram once daily, while the maximum recommended dose in gouty arthritis from ancilla-cox is 120 milligram once daily. And the other product I will highlight in just few seconds. It's called Acticola-C. It's collagen, ascorbic acid, and rose hips. Collagen hydrolysate 5,000 milligram, and it's marine source. I would like to just highlight that this is only available in the Egyptian market. Acticola-C components collagen hydrolysate 5,000 milligram. Rose hips act as an anti-inflammatory effect, anti-arthritic effect to 50 milligram, 500 milligram, and vitamin C 57 milligram. In a few minutes, just highlight the benefits of Acticola-C. First of all, its taste is very different than other tastes available in the Egyptian market, and thus this ensures to your patient will complete his treatment. This product for osteoarthritis will complete his treatment without any complaining concerning the taste. And this is a real picture comparing between Acticola-C and other collagen markets available in the Egyptian market. And this highlights or illustrates how much is Acticola-C is taste and purity is different. In conclusion, Acticola-C improve patient quality of life and reduce the joint pain, reduce the non-steroidal intakes, shortens the time of effect occurrence 4 weeks. This combination shortens the time effect to 4 weeks. Instead, the patient who take collagen only will last for 12 weeks. So in 1 month, in almost 1 month, the patient will come better than the first time he come to you. Excellent solubility that ensures that the patient takes the whole dose without any precipitation in the that he will not use of it. Adds natural orange taste. Patient is really is not complaining from taking as he is taking a drug. Finally, is a sugar-free and safe for diabetic patient. We now have 2 packs. First pack, economic pack, contains 30 sachets. Its cost is 330 pounds and taken once daily that lasts for 1 month. And the other pack is 10 sachets for 130 pounds. Thank you, Dr. Yasser, and thanks the Egyptian Pediatric Orthopedic Society for participating in this conference.
شكرا جزيلا دكتور بولس على محاضرتك، واحنا بنشكر جدا شركه ايفا فارما على السبونسرنج بتاعها للويبينارز اللي هي بتاعت الجمعيه بتاعتنا. شكرا جزيلا دكتور بولس. Now we are going to our next presentation. Dr. Khalid is going to introduce Dr. Anna. Dr. Anna, I want to say that Dr. Anna has really some amazing work that I personally saw and appreciate. Dr. Anna traveled all over the world to help and do Ponseti method totally for free for poor children in poor countries everywhere. And Dr. Khaled, can you introduce Dr. Anna?
So it's a pleasure to have her, Dr. Anna, with us tonight. And she was born and raised in Barcelona, dedicated to pediatric orthopedic since 1995. And since 1997, when she met Dr. Ignacio Ponseti, she started to adopt the method of Ponseti. She's dedicated by 50% of her practice to treat club feet, 100% with the Ponseti method. She did a lot of volunteering in developing countries like in India, China, and the Dominican Republic. She had more than 200 oral presentation, and she's now working in a public and private clinic, mainly dedicated for club feet. So without further ado, we are welcoming Dr. Anna. Looking forward for her talk. Dr. Anna.
Hello, how are you? I hope that you can see my presentation. Is everything okay?
Yes, yes.
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 First thing I want to thanks to the Egyptian Pediatric Orthopedic Society to invite me, especially to Dr. Yasser, that is a good friend of me from a long time. And I want to apologize if my conference is changing a lot of the ideas that you have hearing all of the afternoon. So my idea is to transmit you that the method of Dr. Ponseti is so magic that you can treat everything with Ponseti method. Okay? So I will talk about the treatment of other children and adults with clubfoot, and I try to give you some of my tricks in these challenging cases. So I've been working for a long time in one public hospital. Now I have my private one. I was founder of the Ponseti International Society, and now I'm helping to the Global Clubfoot Initiative because I think this is a society that is helping to everyone to know about Ponseti method. So the first thing that I want to explain you is that when you found a patient that is an old patient of an adult, you have to know how to measure it. And the first assessment is, and measures are not easy to do. In little child, usually I'm using Pirani score. And of course, you have to do a first assessment to know if this patient has anything else that is not only clubfoot. You have to do a clinical history, a chart. You have to explore the spine, the legs, the arms, everything. But in all children, when you know for first time you meet them, you need to know what kind of food is this neglected one. You have to adapt the Pirani score because the Pirani score was a score to measure the evolution of a little child. So what I'm using is more or less the adapting Pirani score, and you can do it because it's a very easy score with 6 items that are evaluating the hind foot, the forefoot, and in these cases you can use it very easily. And what is more important, you have to know how flexible is this foot. So when you, I think it's very, very important to take pictures of all your cases to register it. And when you are talking about the outcomes, you have to know what is your objective. Why do you want to know the outcomes? If you want to know it or to register it just to publish, perhaps you need one scale, but you can use another scales to know about function. You have the Ponseti scale that is very good about function. You can use the EGPOS, and you can adapt the Pirani score to analyze the deformity, and you don't need anything else. Can you follow me?
Yes, we are following you. Yeah.
Okay, because I don't see your faces, so I don't know if I am talking alone. Okay, so usually you have to know that patients that are older patients or young adults can be neglected. That means that they never have been any treatment. Some of them have some previous treatment, but in most of the cases, this treatment is just adenotomy or some cast and anything else. Some of them are relapsed cases that have been done Ponseti method or other methods, and they relapse, and you have to be able to detect if they have any neurological problem, okay? So, sorry, because of the sound, I will put down. In this case, the girl has a neurological problem, and you have to know that it's a drop foot, and there is something else that is not only a club foot. And the deformity can be total, can be partial, or can be just a dynamic deformity. And you have to be able to identify this at the moment of the first visit. And how you know if Ponseti will work in these cases? I think that any fit, of course, have a different response, but there are some clues that, but there are not strict rules. You can think that a patient over 30 cannot be corrected with method, with Ponseti method, but you have to learn about the feeling of Ponseti maneuver, how you feel as the feet is or the foot is moving with Ponseti maneuver. And you can find patients like this one that is a woman that was 32 with this so deformed feet, bilateral, never treated, and you think, I can not do anything. I just can do an external fixator. And when you go to, you go to the maneuver and you are doing the correct maneuver, you can see that you can get a good correction just with the first maneuver. So that means that if you get correction and you get movement with the first maneuver, you can go on with Ponseti method. I met Dr. Ponseti in 1997, and I can tell you that he hates external fixator. So I cannot understand anyone that tells that the external fixator bases are from Dr. Ponseti, because he hates it. And the response to the Ponseti maneuver means that the feet will respond to the treatment, to the Ponseti treatment. Of course, there are some cases that seem to be different or seem to be difficult. These cases that are short, grabby feet, the cases with previous surgery, the cases that are associated to any syndrome or complex feet, or the cases that have suffered multiple surgeries. But if you see the video and you see how we are doing the maneuver, you know, you see that in these big cases, these old cases, you have to put your hypotenar eminency over the talus that always is over where you think, is always proximal, and you can see how the feet is moving. And if you see this case that is manipulated by one of my assistants, you see that my hypotenar eminency is blocking the talus, and you can see that in some cases, including this one that has a scar in the internal and posterior zone, as you can see in the picture, you can get response. And if you get response, you can do to the Ponseti method. You don't need any external fixator, you don't need any release, anything else. So the idea that I used when I had the option to go to India, I designed a protocol, and my idea was, why not to treat the older children that perhaps are neglected cases in the same way as we treat relapsed cases. And this is the protocol that I developed in India first, after that in Bangladesh, after that in Dominican Republic, and I use it in Spain because we have some cases from Morocco that are arrived to Spain in the same situation you can see in this picture. So why we don't treat it in the same way as we treated these cases? And this was the idea. We are using the protocol for relapses in patients over 11 years, and just with one cast, Achilles tendon, tenotomy, and anterior tibial tendon transfer, we can get good results, and are including cases of relapses over 19 years old, as this patient that was working on the lateral side of the foot. So I performed this graphic, and to do it easy, I don't know if it's so easy, but if you have a clubfoot and was less than 3 years, you have to treat in the classic line with Ponseti cast. If you get to 60 degrees, you have to think to go to tenotomy, and after that to the brace. But if you have a case over 3 years, and I tell over 3 years because the third cuneiform is ossified over 2.5, and in these countries, as your country and a lot of countries of all the audience, you cannot have a second opportunity. I know very well that these cases, if you offer them a long period treatment, they disappear. So it's better to offer them something that it works than something that is not possible to do it. So over 3 years, what I'm doing is going to transfer with previous cast that you don't need to go to 60, you just need 40 degrees of abduction, and doing the transfer with 2 weeks of long cast, 4 weeks of short cast, and some sprint to help to adapt the situation of the new plantar zone, because the patients that are neglected never have a thick skin in the plantar zone, and you have to know that they will have discomfort in the plantar zone for a long time. So this is the reason, because I am trying to use some brace, some AFO, to help them to adapt. So if you are thinking on a 19 years old patient with previous posterior medial release, that means that is a difficult, very difficult case. I can plan when I manipulate him to do 2 casts, because it's the cast I need to get 40 degrees, and after that I will do a total Achilles tenotomy, a percutaneous fasciotomy, and anterior tibial tendon transfer. That means that I forget all the middle of the table I design. I am going to over 3, and I am going to transfer, and I'm going to the protocol after transfer. It seems quite, I don't know the word, is something that can do a crash in your brain, but I will show you a lot of images and you will see that it works. So you don't need to do any external fixation for this patient. You don't need to do any release. You just have to believe on the possibilities of Ponseti method. What are the tricks of the previous cast? Of course, the maneuver is not the same as the maneuver you are using in newborns. So you need your 2 hands. You have to take a lot of care of not blocking the calcaneus, and you have to go a lot of proximal to block the talus. You need long cast, because if you are doing a short one, you need more cast to get the same. So if you want the patient to be a good patient and a patient that comes to your clinic, you have to offer the patient a short treatment. If you offer a long treatment of 2 months, 3 months, you have a high possibility of losing the patient. So long cast, to put the cast in the sitting position, as you can see in the pictures, and first you have to correct the cavus, the same as the Ponseti treatment, and after that go to abduction to get 40 degrees. You can see here my assistant, and she's helping me with cast, and if you need, you can put a spring over the knee to help the cast to be a little bit more resistant. But I am using, as you see, plaster of Paris, the typical cast. I'm not using any cast that is expensive. This is a cheap method and a short method, and you can get it the same results or perhaps better results if you compare with other methods. So when we are going to surgery, sorry? Sorry, because I don't hear you. Can you hear me?
Yeah, just so
Yeah,
you
okay.
can continue. Yeah, please. Sorry.
Okay, I can continue.
Yes,
so when you have to get it 40 degrees of abduction, the the surgical plane is the same as you are doing the relapse. Achilles tenotomy, that is total, not with 3 cuttings, not with open surgery. An anterior tibial tendon transfer, that is total, not EMI. And a percutaneous fasciectomy that helps to improve the cavus in some cases, not in all cases. And there are some tricks that I am using. I'm attaching the tendon with anchors. Why with anchors? It's not a question of money. I don't win money with anchors. But if you are in a country that you know that the patient won't keep very well the situation of the cast, it's better to put an anchor than to put a button in the sole. So there are some anchors that are really cheap, really cheap. You can get anchors from India from $100. So that means a really cheap thing if you compare with the problem of having an infection. I'm doing a stretching of the capsule after the tenotomy. That is a soft maneuver with continuous pressure and is helping to the capsule to stretch. And I'm adding minimal surgeries, especially for toes, for the adductor of the first toe to help the foot having a better position. And sometimes if you have a big or very important cavus, you can think on the function of the peroneus longus, that no one is thinking on that. So in some cases that you have a big important talus that is not reducing with the fasciectomy, you can do a peroneus longus to peroneus short. And it works very well because you can see as the foot is relaxing after cutting the peroneus longus. After treatment, I'm doing a quite fixed protocol that depends on the surgery. If you have done a tenotomy, because in some cases perhaps you need just tenotomy or fascia, you can use 2-3 years below knee cast with weight bearing immediately after surgery. If you are doing a transfer, you can use a 6 weeks below knee cast with weight bearing depending on the pain. And I like to use EGPOS during 2 months or 6 months, depending on cases, to get the patient to adapt the sole to be in the floor, because they have been having a callus in the lateral zone, as you know, and they have a very soft skin in the sole. So that means that with this, as this case that was an arthroapotic boy that is working on the knees, he cannot walk on the feet, and this feet was so rigid, but the knee was like a stick. So this was the reason because I began with this one, that the knee was mobile, and I put A4 to help him to change the proprioception and to change the feeling of the sole. And in some cases, you can help them with exercises, to do bicycle, to walk, do some movements of the feet, anything you think is helpful. And I can tell you that I have some patients with long-term outcomes. I'm not telling about 2 years of follow-up 1 year of follow-up. There I have patients from 2009, 10, 11 in India, patients from 2016 in Bangladesh. So that means that I can see them for a long time. And you can see this patient of 23 years old with neglected bilateral club feet with the cast and after cast, and he's going after 3 casts, tenotomy, fascia, and transfer. He is able to go by bicycle, and he was not able to walk. The friends are helping him to go to any place because he was not able to walk in the position he has before. So this is one of my longer follow-up cases. He was a 21 years old girl. I don't believe that I can do anything for her. You have to think that all these cases were refused to do any release, any soft tissue surgeries. They are prepared for bone surgeries. And I perform first like a functional cast, short one, to see how the foot is responding to my manipulation. When I see how it works, I perform a long cast, and after 3 casts, I perform the transfer. You can see here the callus, the transfer, the fasciectomy, the tenotomy. I was convinced that she will need osteotomy of the first metatarsal, but in this hospital I cannot do any bone surgery, so I just think that I can improve the situation. And this was the patient after 1 year of the surgery. But the one thing that is typical in India is that if you have this deformity and you are a woman, you cannot be married. And she was married. I don't know if it was a good idea, but okay, she was married and she was part of the society at that moment. And she has a newborn, she has babies, and she has no problem with the foot. This is another case of 12 years of age with so relapsed club feet. I performed cast. Was not easy. I need 4 casts, but this was 9 months after the transfer, tenotomy, and fasciectomy. At that moment, I didn't did the tenotomy of the adductor of the first 2. I think in this case, perhaps it has been done a good idea because you see the first 2 is pointing in, but in India, I think that the most important is that they cannot go to school, and after that, Mohammed can go to school. That means that he was part of the society, and he was not marked because he has a club foot. You can see Jimu, 11 years old. Those are her feet. You can see this feet, how it's pointing to the back of the girl. She never have any treatment. The physios of the foundation where I was working performed 10 casts. If you are not used to do this kind of cast, perhaps you need 10. I think that you can do it with less, but it's okay. If you need 10 and you get it, it's okay. And when they get to 40 degrees, I perform Achilles tenotomy, fascia, and transfer. And you can see how the feet are changed, but the most important, how the face of the girl has changed. This is the most important, because we are treating patients, we are treating persons, not treating feet. This is Edris. Edris was 26 years old. I'm almost finishing because I put all the cases at the end. He has a right neglected club feet with amniotic bands associated that, as you know, is a problem that means that the foot that is associated to that has a high tendency to relapse and a difficult response to the treatment. But after 3 Ponseti casts, Achilles percutaneous stenotomy, percutaneous fasciotomy, and transfer, you can see him that he never gets shoes before the treatment. And now he's not able to remove the shoes because he feels that it's normal. He was the captain of cricket team of handicapped persons in Bangladesh, and now he's a lawyer because he feels normal and he is not for anymore any captain of a cricket team of handicapped person. This is a patient. This is a very interesting one. She gets in this condition, short foot, neglected one, absolutely deformed, and I get to control her 7 years after the treatment, and she was so happy. She's studying for being teacher, and she's able to walk with good mobility, with good shape of both feet, and the clubfoot was just one. So my personal tricks in these cases are, if you allow me to give my tricks, is that I aim you to treat neglected patients in the same way as you treat relapsed cases. You have to know that the response to Ponseti maneuver, if you are doing the proper one, if you are not doing the proper maneuver, you never get response, is directly related to possibilities of Ponseti treatment. You have to use a good technique to cast with 2 hands, using the anatomy to localize the talus that is always proximal as you think, block it and cast it to get 40 degrees of abduction with minimal surgeries, as minimal as a transfer. You can get very good and long-term results. You have to know how to treat them in the post-operative period, and most cases of them are possible. I just refuse 2 cases in all my life. So that means that more than 95 or more % of cases can be treated on that way and not with any more aggressive surgeries. So thank you to all the audience. Thank you to Egyptian Orthopedic Pediatric Surgery, and thank you, Yasser, to invite me. And I don't know if you will invite me again because I break all the anterior ideas, but I cannot tell anything different what I'm thinking. Thank you very much.
Thank you very much. Thank you so much, Dr. Anna, for your presentation and your great work. Actually, everyone in the field of pediatric foot and Ponseti method know very well about your amazing work and cases you treat. Now there are some questions.
I know, I suppose.
I can see Dalia from Chile. We are welcoming her also.
I am Sepúlveda, my friend. Yeah.
Dalia is asking about when you say percutaneous fasciotomy, it is really like a fasciotomy, just cut?
It's really like the fasciotomy? Sorry?
I don't know what you mean exactly.
I'm doing the fasciotomy when I feel that the fascia is tight. It's just a feeling thing. And nowadays I'm more taking more attention to the peroneus longus, but if I feel that the fascia is tight, I prefer to do it percutaneously because it helps. I'm doing it in the, not in the insertion of the calcaneus, just in the proximal tertius of the fascia, and it helps to the cavus deformity that you cannot correct sometimes with cast. Of course, I try to correct with cast, but in some cases I need it.
Mm-hmm. Dalia also is asking about that she prefers to do bilateral at the same time when the patient does bilateral clubfoot.
Of course,
so
I'm
some
doing,
some of your cases
in
one
all
side
cases,
only.
yes, in all cases I have bilateral deformity. I'm doing bilateral. In some cases, you can have one difficult foot and another one that is soft, and you have to begin in the difficult, and the difficult is doing your rhythm, you know, and you can begin with the difficult, and you can plan how much cast, how many casts will need the soft one. And if you plan 4 casts for the difficult and 2 for the soft one, I began 2 casts, and in the third, I began with the soft one. But I'm doing always the 2 feet at the same time. I never do one and the other, never.
Okay. And Dr. Mohammed Al-Wahsh asking, what is the protocol of brace in adult? Dr. Mohammed from Iraq is asking, what is the protocol of brace for adult?
I'm not using braces. I'm using just transfer, and I'm just using the EFO for comfort, not brace, not abduction brace. I'm doing the transfer, so I'm not using brace. Abduction, if you are thinking on abduction brace, I'm not using it. Because if you have a 30 years old patient, you cannot tell him to use an abduction brace for night. He has a wife and he needs to move a little bit more, you know? So it's better an AFO to walk, and at night to be free, nothing at night.
See, Dr. Brandon Smith asking, may I know how should we classify clubfoot in our clinical practice? Is it idiopathic versus non-idiopathic, rigid versus flexible, or typical versus atypical?
Oh, this is a classic question. I in my practice, I'm using, I describe the foot because for me to classify the feet is difficult. I think that anyone is different. So you have some cases that have atypical characteristics from the beginning, or you have some patients that in the third cast you can feel that is something strange that you can put in your chart. It seems to be atypical. About rigid of not rigid, I think, is absolutely depending of the one that is moving the foot. Because
Okay.
I was reviewing a lot of previous treated patients, and all of them are rigid. And when you move it in the proper way, you can tell it's not rigid, it's soft. And that means that if you feel that all your patients are rigid, you have a problem. Your maneuver is not perfect. If you have one rigid over 10, perhaps it's okay. But if you have half rigid and half flexible, I don't think it's proper. I think it's something wrong in your technique. And it is my opinion. I know that Yasser, you never will invite me again, but this is what I think. So I cannot tell any another thing. I think I think what I'm thinking. So
do you do complete Achilles stenotomy in adults?
Yeah.
This is question from Professor
any,
Rosasi.
at any age, complete.
What do you say?
At any age. It doesn't matter the age. Complete stenotomy at one point. We discussed with Dr. Ponseti about it because I had the idea in 2004-05 of doing 3 points lengthening in patients over 2 years. And I showed him one case and he told me, Anna, and what's the reason to do 3 points lengthening and why not one stenotomy? You have 1 zone of scar or 3 zones of scar. And I said, I don't know. I learned of you. So I don't know why I'm doing 3 points or 1 point. And he told me, I'm not sure that I have the absolutely right, but why not to do a stenotomy? And I had Achilles, a breaking of Achilles 2 years ago, and I never get to surgery, and it's totally recovered. So this is the same thing I am applying to myself. So that this is the best way to convince anyone. So I never touch my Achilles. It's break and it heals. Nothing.
Okay. Last question from Professor Edward from Alexandria. He's asking, in a 3 years old arthrogrypotic child,
yeah.
when you have done a tenotomy and you get a relapse, with recasting, if you reach a plantigrade position, would you be happy or rather do a second tenotomy?
When you are treating arthrogrypotic, you have to know that it's not normal. And you never have to put your objective in a normal foot. So it's a syndromic one. So that means that what you need is to be functional. If you have a plantigrade that is functional, don't do it. Don't do anything. You can have and keep the tenotomy, the second one, for a worse situation. You understand me? So if you have a mild equinus, it's the same. The children with arthrogrypotic can walk very well with a mild 10 degrees of equinus, and you don't need to get 10 degrees of dorsiflexion. And you have a long way to work with them, to live with the patient. And if you do a tenotomy every time that you don't get 10 degrees of dorsiflexion, in the future you will go to the relapse, to the release, and the release is the absolute absolutely fracaso, ¿cómo se dice fracaso? When you fail, absolutely the method. And when you fail, the patient. I review all my patients with Ponseti method, and the worst one were the ones that I decided to go to posterior medial release because I was not absolutely satisfied. One of them was visited by Dr. Ponseti and tell me to do a posterior medial release. And these cases were the worst. So it's better an equinus than to have a rigid, non-functional foot and short one, because when you do a release, no one is explaining about it, but if you have a spina bifida or arthrodeposis and you are doing a very a release when the patient is very young, you are affecting the growing of bones, and most of these cases have a short foot, and when they are 16, they have 80 kilos, and they cannot maintain standing because they have a 29 number size of shoes, and no one is thinking on that.
Okay, Anna, thank you. Many asking how many manipulations and casting in average you need to correct adult clubfoot or
in most of my experience, as I'm going to do cooperation in other places, so I have to limit my number of casts, but I'm doing the same in Spain with Moroccan patients. So I'm doing 3-4.
Just 3-4.
Yeah, because I get 40 degrees. I don't get 60, but with 3-4, I'm getting 40, and I can go to the surgery.
So how many weeks you need to do this totally?
No, just the same as newborn. You can change it every 7 days. The same. You can do the short or the long protocol. It's the same. It's working in the same way.
Okay.
In fact, there is a Pirani has done
from the beginning to the end. How many weeks it takes approximately?
If you change every 5 days and you need 4, you need 20 days. Mm-hmm. Not more.
Okay, Professor Battuti is asking, Professor Battuti is the president of Egyptian Pediatric Orthopedic Society.
Wow.
He's asking a question. He noticed that during a manipulation, you don't put your thumb over the talus as a typical Ponseti manipulation. He noticed on your video or photos that you don't put your thumb over the talus as the classic Ponseti.
Yes, so, I don't put my thumb because it's an adult, and you cannot put your thumb. If you put your thumb, you will have an ulcer. You can have a shore. So it's better to put your hypotenar eminency, as I marked, because it's more round. You don't do a pressure in the talus. And you have to educate your hand to that. It's not you cannot get it in the first time because you have to know how to feel it, but you have to feel it the head of the talus in your hypotenar eminency, and then with the other hand you have to move, but not moving with doing a lot of strength. You have to move it softly. It's not a question of being the strong man of the world. It's a question, I am a woman, so I'm a weak woman. I have not force, and I can do it. So all of you can do it. But it's like you have to do a dialogue with the foot. It's like a dance. You have to feel it, to learn to feel it, and to learn to move it, and to understand how it's moving. In the same way as people that is blind learns to understand the braille system. It's the same. They are able to understand and to have to read anything with points, with little points. It's exactly the same. You have to educate your feeling to understand the eminences of the foot. Not is the same maneuver, but if the foot is big, you have to need a different. You cannot use your thumb because the thumb is pressing too much. So it's better to use your hyponeural eminency. This is the reason, but not because you are doing a lot of strong. It's not the same. It's not.
Okay, Dr. Really, we appreciate very much your presentation.
Hope you invite me again.
Amazing, unbelievable cases. Thank you so much. Thank you. Thank you. We appreciate.
Thank you.
Hope we meet again in future in reality rather than on the web. And please stay safe for you and your family. Wish you all the best. Thank you very much. Thank you.
Thank you very much.
Thanks.
So now we are going to move to our next presentation with Dr. Miroslav Zivkov from University Hospital of Varna. Dr. Khaled is going to present Dr. Miroslav. Dr. Miroslav, you are ready? Hello, Dr. Miroslav Zivkov.
Yes, I'm ready.
Dr. Khaled.
So Dr. Miroslav from University of St. Anna, Bulgaria. He's specialized pediatric orthopedic since 2000, and he's have a good interest in clubfoot surgery, limb reconstruction, and lengthening. We are very happy to have you tonight, and we keep the best for the last, and we are waiting for your talk. So please go ahead.
Just a moment. Do you see my screen or not?
No, so just let me stop my video.
Yes.
So are you sharing your screen now?
Yes, I'm trying to share it.
Yeah, now we are seeing your presentation.
Okay. First of all, I would like to thank you for an invitation to be a part of the great doctors and great webinar of clubfoot Ponseti treatment.
Dr. Zivkov, we cannot hear you well. Can you please speak loudly or check your mic?
Just don't. I'm trying to. Do you hear me now?
Okay, better. Yes, yes, better.
I would like to present my too many times revisit treatment strategy for atypical club feet, because you know this is very important to learn how to treat untreated, impossible treated atypical club feet, because these club feet do not respond to normal treating protocol. So you know that the Ponseti method is gold standard, but what to do with teratological atypical complex club feet? On 2002, three. First, I mentioned Matthew Dobbs, not Matthew Dobbs, excuse me, Fred Dietz, God bless him, and to present my work to Professor Ponseti, and on 2006 we combined our results from a multiple centric study, and we developed this modified treatment protocol for atypical club feet. So what is my experience? From 800 club feet patients from 2003, 36 were with atypical club feet. Half of these were treated in another hospital, and as I mentioned, there is an experience learning curve. What are the anatomical peculiarities of atypical club feet? First, the forefoot. Feet are short and stubby. There is a severe plantaris, severe chaos of the whole metatarsals, and deep soul transverse crease. Toes are hyperextended. And the hind foot, I think the devil's is in the hind foot when we talk about the atypical club feet, because of severe equinus, very severe equinus, stiff fibrotic Achilles. There is I call it posterolateral fibrous knot. This is a posterior capsule, combine it and glue it to peroneal tendon sheet. Posterior calcaneal tuberosity is in equinolateral position, and extremely tight white Achilles is tied to the posterior lateral knot, and this block the movement of the calcaneal tuberosity. So, fixes tuberosity, you can see on the atypical club foot. This is the normal movement of the Ponseti movement. See how the tuberosity goes to the medial. But when the tuberosity is fixed here by fibrosis, you cannot move. This is the problem with the atypical club feet. I can't put my finger here, but because I have to wear this model. So our revised treatment strategy is referred to the primary treatment and treatment of relapses. So what we do? For foot abduction and cavus correction, you know, and correction stops about 20-30 degrees. And if you continue with correction, it will appear the lateral crease. Why? Because of the stopped movement of the calcaneal tuberosity. And we will bend the whole foot in the midfoot. So, in this point, I decided to make earlier tenotomy, and that is the modified treatment, first modified treatment protocol. In this point also, the foot became to slip because of severe equinus. And here you can see the hyperextended first toe. So the modified treatment protocol consists this cast molding of the forefoot, you have to extend the hyper cavus, and after that, to just to push to block the tuberosity in dorsiflexion position. Also, to prevent slippering of the cast, we have to make 110 degrees flexion of the knee. So when the correction stops in 20 degrees via equinus, we do a lithotomy with our developed pull-down procedure. So here is the tenotomy. Here's the result after tenotomy. You see the under correction. That's why I decided to use sand retractor to put it into the tuberosity and to pull down the tuberosity into the dorsiflexion position and medial force. So I made some ultrasonographic intraoperative investigations, and you can see how after the pull down, the distance between distal tibia and nucleus of the calcaneus is increased. The second point is to adapt the foot abduction brace to a typical club feet. Before 2006, we used this type of brace, but after that, we use only, in atypical club feet cases, we use only plantar flexion stop brace. Because we found that it decreases the posterior contracture during the time, and it increases 2-3 months. What are the results? All 34 feet were initially corrected, in average of 15 degrees dorsiflexion, but 35 degrees relapsed. 2 relapsed on 1 year due to the FAB compliance. We do recasting and in one case retinotomy. And we have 10 late relapses on 4th, 6th, and 8th year, gradually decreased dorsiflexion in years. We increased the time of wearing during the years of the brace. We started 2.5 years in 2003, and now I recommend 5 years of wearing brace. So, why do we have 35 degrees percent relapses on this 6-8 years? First hypothesis is that in atypical club feet, tendons and muscles grow slowly in calf area due to the severity of club feet, and primary or secondary developed flat top tails. Because of nutcracker's effect, when we try to, after tenotomy, to increase dorsiflexion, we smash the talus like nutcracker. So with this pull down technique, I try to decrease this dorsiflexion force on the tails. But I don't know is this flat top talus is due to the anomalies of the atypical club feet. So I would like to present two of my cases. here we made modified Ponseti treatment with pull down technique. This is one result of 1 year. You can see the lateral crease is still on. Result of 8.5 years old. He's no flat top tails. Everything is okay. He refused to make a picture now because he's very big guy, young guy. He's taller than me, and didn't want to make a picture of his feet. So this is the first my atypical club feet case, Michaela. I do only early tenotomy of this case, not pull down, because I didn't develop this method yet. So on the age of 4, everything were okay, but at the age of 4, the mother decided to make electrostimulation of calf muscles because of the thin calf of the left feet. And what we have a relapse. We made several recasting, retinotomy, and ATTT, but you can see here the flat top tails. I discussed this case with Professor Ponseti. We came to him with the patient, and maybe it was better to make supramalleolar osteotomy, but the parents refused to make another operation. So she's doing well, no problem. She's 18 years old now, and there is no any compliance. So what would we do with late relapses? I make minimally invasive strategy. Gastrocnemius resections or whole achillotendoptomy with anterior tibial tendon transfer with anchor. And I do also intramuscular tenotomy of the of the tibial posterior, because I think that we have to decrease this varus force of the tibial posterior muscle. So, and you can see the results. And for the flat top talus, I found that ADTA is 90 degrees in these cases. Normally, it's about 80 degrees. And this is bone equinus. So I decided to make guided growth just to increase the dorsiflexion, bone dorsiflexion of the ankle. And this is unpublished results. And I think that it's okay. It works. This is one of my patients that previous week I removed this 8 plate. So this is at the beginning. And this is after removing the, before removing the 8 plate. Okay. So as I mentioned, we can treat first primary atypical club feet and the relapses by this modified treatment protocol. So thank you in advance for the attention.
Thank you very much for this talk, and it's very difficult. We all know about the atypical club feet, and we have a couple of comments here. One of the comments about the, do you think that the atypical creases mostly are iatrogenic? So it's a deficiency in the technique?
Could you repeat, excuse me, because I'm trying to open again my Zoom. This is first time I use it. And
that's okay. So it's a comment about the atypical creases or that being found in club feet, and the comment saying that most of the atypical creases in the club feet are iatrogenic as regarding deficiency in the technique.
No, I think that atypical creases are atypical creases, but if I see the atypical case from another hospital, yes, it could be iatrogenic. Iatrogenic is slippering the cast, and you can have atypical creases during the slippery cast. But when I start treating a case, when the case stopped moving, the abduction is stopped moving, it's about 20, 30 degrees, it's atypical. And I'm going to the operating room. I'm not waiting to do more casts. I'm just going to the operating room to increase the dorsiflexion. And sometimes I change the cast to increase the dorsiflexion in 10th day after tenotomy.
Okay. So Dr. Ashraf Khanfour had a comment. He argued that the flat top talus are a false thought, and it's false position talus, radiographically malrotated talus in the mortise. So what do you think about that? So it's not truly a flat top, but because the talus is not well positioned, so that's why you get the impression that it's a flat top.
No, it's flat top. I made some CT scans of these flat tops talus, and it is flat.
Okay.
But sometimes it's not well rounded like the trochlea, you know.
Yeah.
This is not truly flat top talus, but maybe this is some stage of flat top talus, maybe 0 first stage. But when you have good soft tissue dorsiflexion, but not good dorsiflexion, I always thinking about this bone equinus, I call it.
Okay. So Dr. Muhammad Al-Sayed, his question is, how many casts are needed in your hand to correct those atypical cases?
5.
5 casts.
5, maximum 6 casts.
And if you allow me to add one more comment as regarding, I've seen that you are doing the tenotomy in the OR, so it's not an outpatient procedure. So you are doing it in the OR, in the operating room.
Yes, because when I was in Iowa, I saw that Professor Ponseti did not do tenotomy into the room. ambulatory room.
Yeah.
He did into the ambulatory room, but with the anesthesiologist.
No.
Oh, I saw this. Yes.
No.
I saw the anesthesiologist with the intravenous anesthetic. And after that, he put some lidocaine. And he told me that if the patient go into the operating room in Iowa, it will cost $5,000 more.
Yes. So Dr. Anna, it seems like there's a crossfire here. So Dr. Anna, want to comment? Yeah.
Okay, no problem.
Yeah. So.
I cannot have the video because Yasser blocked me. Sorry. But I'm not agree with you. Dr. Ponseti never put a patient in the operating room. I've been with him since 1997, and he said that he had a problem with the first one, and he never repeated a general anesthesia in any patient to do a tenotomy. I saw a lot of tenotomies with Dr. Ponseti, and no one has been done in the OR. No one. So I learned with him on that way. So you cannot say that Dr. Ponseti says that because he wins $5,000, because this is wrong and you are telling lies. Sorry, but this is on that way. And the other thing is that if you have an atypical case that is not atypical from the beginning, you have not case and the first exploration, the problem is your manipulation. And you have to analyze it.
Yeah, so we'll take in this comment, and so I think I want to thank you all for being with us. It's a pleasure, and we enjoyed it a lot, and we'll pass it to Dr. Yasser Batrawi for the final talk, and wish to see you all.
Okay, thank you very much for everyone attend this webinar today. I appreciate very much all the presentation done by Milan, Monica, Dr. Anna, and Miroslav. Thank you so much for all of you. إلى لقاء تاني إن شاء الله مرة ثانية مع جمعية جراحة عظام الأطفال المصرية، وإن شاء الله في شهر 8 هيكون لينا لقاء على البيدياتريك فود مع مش عايز أقول دلوقتي، بس إن شاء الله هيكون eminent speakers يعني. Thank you for everyone. Thank you so much. Bye bye.
شكرا دكتور ياسر.
باي عنا، باي ميرو، باي باي.
دكتور ياسر.
ايوه.
حابب اهني حضرتك الاول على الميتنج. انا بولس عياد ايفا فارما.
انا اهلا وسهلا، مش واخد بالي مين بيتكلم.
انا بولس عياد يا دكتور ايفا فارما.
تمام اهلا وسهلا.
حابب اهني حضرتك على الميتنج.
شكرا جزيلا.
وان شاء الله هنبعت لحضرتك التسجيل.
شكرا جزيلا. الف شكر.
ميرسي يا دكتور. مع السلامه. اتفضل. باي باي.
إذا أمكن التسجيل دزونا إياه. شكرا، مع السلامة.
شكرا.
إن شاء الله.